We are live. Good evening, everyone. Welcome to the 95th episode of the AJCC PG Initiative Program. And this program is basically targeted for our young postgraduates and the young ophthalmologists. Today, in this series, we have a wonderful talk on the genetics and the counseling on the retinoblastoma by Dr. Rolika Bansal. She needs no introduction. She is one of the brightest stars of All India Ophthalmic Society and trained under the master of the masters, Dr. Shield ma'am and Dr. Santosh Anawar sir. And for that, today we have an expert panels. These expert panels are himself is a legend in the field of ophthalmology and oculoplasty. One is Dr. Samiksha. She is from the Narayan Netralaya, Bangalore. Another is my old friend, Dr. Devjyoti Tripathi. He is from LVPI Bhubaneswar. And then the Dr. Suganeshwari Ganesh ma'am. She is from Sankara Netralaya, Chennai. With this introduction, I would like to call Dr. Rolika to start the program. Dr. Rolika, please. Dr. Rolika?
Yes, sir.
Yeah.
Yes, sir. Thank you so much, Deepak sir, for letting me be a part of the webinar. And I'll just share my screen and share my thoughts about genetic assessment and counseling. Is my screen visible?
Yes.
Okay. So, a very good evening, everyone. I'll be talking on genetics in retinoblastoma and the counseling related to genetic counseling in retinoblastoma. So, when we talk about this topic broadly, it comes as a long question for postgraduates. It even comes as a short question for postgraduates. So I try to enlist certain things before I go forward. So when you try to frame your sentence or your answer, talk briefly about retinoblastoma first, then about the gene, about the effect on the cell cycle, talk about the Knudsen's hypothesis and beyond, then talk about the inheritance pattern, the AJCC modification, special features of the heritable retinoblastoma, the clinical applications, how the genetic testing is done, what is sibling screening, and how the genetic counseling is done. These are the pointers which I would say that will help you frame your answer, will help you frame your thoughts, and even in Viva it will help. So I've tried to put it together in an organized manner. So when we talk about retinoblastoma as a disease, I would say that retinoblastoma is a malignant retinal tumor. Approximately, there are 1,500 new cases per year in India, and it affects young children mainly, has genetic predisposition related to mutations in the RB1 gene. This is broad, brief explanation of what retinoblastoma is and how it is in terms of genetic correlation. So retinoblastoma gene, when we talk about, so RB1 gene is a tumor suppressor gene. It regulates the cell cycle. There's a misnomer. A lot of people feel that RB1 gene is causing the disruption. It is actually regulating the cell cycle. And the long arm of chromosome 13, everybody talks about which is the gene responsible, which is the chromosome responsible, mention it as 13q14. It has 27 exons, 185 kilobase of genomic DNA. So these are all the pointers that you can think about when it comes to retinoblastoma gene. So when we say specifically this is a cell cycle which has been beautifully explained, that RB1 is a tumor suppressor gene. And what it means is it binds with the E2F and it prohibits it from it prohibits progression from G1 to S phase. And therefore, that's the checkpoint. And it prevents continued cell cycle proliferation. Now, what happens is that RB1 gene gets mutated either by deletion or nonsense mutation. When that happens, it's not able to control E2F and there is continued growth by progressing into the S phase. And that's where retinoblastoma occurs. In fact, a lot of diseases occur, a lot of RB gene related malignancies can occur. So when you talk about Knudsen's hypothesis, we've been all hearing about it and we have learned about it from the beginning. And when we talk about it, what it means is Knudsen hypothesis has two arms. One is the germline retinoblastoma and the non-germline retinoblastoma. Talking about germline retinoblastoma is that the patient has had an inherited mutant RB1 gene which underwent somatic mutation over time, and therefore there are two mutations that the patient now has, which results in formation of a retinoma, not yet a retinoblastoma. And the non-germline mutation means that there's a healthy RB1 gene. The patient is not carrying the germline mutation here and gets a first somatic hit, which could be due to environmental reasons or any other reasons, and again develops a hit and develops both the mutations, resulting in formation of a retinoma. This retinoma eventually undergoes genetic and epigenetic events, resulting in a retinoblastoma. So, when we talk specifically, retinoma is the precursor of retinoblastoma, and 4% of retinomas may undergo malignant transformation. It is important to know that because we need to make sure that retinomas are not taken on the side and taken as rest. You need to monitor them because they undergo malignant transformation in 9.2% cases in 5 years and 15.3% cases in 10 years and 20 years, which has been very nicely demonstrated by Shields et al. And if we talk about the percentages, majority of the cases are actually happily non-germline. So germline mutation is 30 to 40% and non-germline is 60 to 70%. And when we talk about age of diagnosis, the genetic component, the germline ones actually present early. The age of diagnosis is by 15 months, whereas the non-germline ones, they present slightly later because we are kind of waiting for two hits. This is how I would remember it. And that would be 24 months. But now this is what we have known for a long time. This is what we've been reading probably from the time of Robbins, I would say. So what is new in that? In addition to the Knudsen's hypothesis, we also need to know that there's something called as NMYC gene or MYCN gene. And therefore, what happens is the amplification of MYCN gene occurs at the DNA level. Here, the patient does not have any mutated RB gene. They have absolutely normal, healthy RB genes, and it still results in a retinoblastoma. This can occur and it should be kept in mind. Clinically, it is slightly different from the RB1 tumors. It is reported in 1 to 3% of children with unilateral RB. Remember, it's moreover unilateral because we're not carrying the genetic component, and it occurs in children younger than 12 months. Histopathologically, these tumors are similar to the other MYCN amplified tumors like neuroblastoma. And overall, I would say that there is no risk for familial transmission or affecting the contralateral eye or other malignant cancers. So, keeping all these things in mind, we can actually be mentally relaxed about the familial transmission occurring in these patients. There's a little brief quote before I go forward, and that is genes are like the story, and the DNA is the language that the story is written in. So it's important to understand the basic DNA of everything. When we talk about RB inheritance, so RB inheritance, before I go in details of that, we must remember that 25% of germline mutations are familial. These are very strange numbers, but to remember that if they are familial, we consider them as autosomal dominant. And 75% of germline mutations are non-familial. That is, they're not coming from a particular parent, and these are de novo. And all cases of bilateral RB have germline mutations. 30 to 33% of unilateral RB also have germline mutation. And in 5% patients, genetic analysis might not even identify the mutation. So we must keep it in mind that even if the patient does not have a genetic component, they still can have a germline mutation component. Now, when I talk about RB inheritance per se, a very beautiful table has been given by Rosa RH, and it was actually generated by Abramson himself. So this shows that if a parent has bilateral retinoblastoma, then what are the chances of the offspring having it? If it is unilateral retinoblastoma that the parent has, what are the chances of the offspring? And if the parent is unaffected, then what happens? So I'll take you through this very briefly. When we say that the parent has had bilateral retinoblastoma, that means 45% of the children of that parent can have retinoblastoma. And this continues forward, and we would say the bilateral component is more common when the parent is also bilateral. And again, the sibling or the next offspring is also going to have 45% chances. When we talk about the parent having unilateral retinoblastoma, it's less likely for it to be germline. So it is 7 to 15% that the offspring is affected. And again, if the offspring is affected, they would be moreover bilateral going forward, even if the parent was unilateral. And there are more chances of the sibling having retinoblastoma now because it is presented in one offspring. So the next child has 45% chances now. But if the offspring is unaffected, then the chance goes back down to 7 to 15%. It's slightly tricky and confusing, but important to remember. And if the parent is unaffected, then less than 1% chances of the child being affected. But if the child is still affected, then the sibling can have 5% chances. So the list goes on. And if the offspring is unaffected, again, the percentage goes down to less than 1%. Now, it can be confusing, so I summarized it in 5 pointers. If the parent has bilateral RB, it would be 45% risk of offspring with RB. And I would say that the range has been given as 45 to 50% because a lot of researchers have been working on the genetic component. If the parent has unilateral RB, 7 to 15% of the risk of the first offspring with RB. If the parent is RB and offspring is RB, then the sibling has 45% risk of having RB. If the parent has RB, offspring is more likely to have multifocality. And if the parent is unaffected, less than 1% chances of the offspring with RB. But if the parent is unaffected and offspring is bilateral RB, the sibling has higher chances. And if it is unilateral RB, then sibling has less chances. These are confusing numbers, but important because when we are dealing with counseling, we need to tell these numbers to the parent. The first thing the parent asks is, what are the chances of my next child to have retinoblastoma? So it has been put together very beautifully by the authors. Now, keeping all of these things in mind, AJCC classification resulted into a great modification. In the 8th edition, they added the letter H, that is the hereditary trait. So H stands for what? They combined the genetic component and they said that if it is HX, that is unknown or insufficient evidence of RB1 gene mutation, could be because analysis was not done. And H0 is when normal RB1 alleles in blood tested with demonstrated high sensitivity assays. And H1 is bilateral RB or RB with an intracranial PNET or patient with a family history of retinoblastoma or molecular definition of a constitutional RB1 gene mutation. That means H1 is when everything has actually been proven. When we go forward, we talk about certain special features which occur in heritable RB, which are moreover not seen in germline mutation. These are related to 13q deletion syndrome. 13q deletion syndrome is that interstitial chromosome deletion or translocation occurs at the 13q14 gene region. And these are seen only in 5 to 6% of all RB children. It's not very common. In fact, in the entire tenure that I have been, in the last 5 years, I have seen probably one case in India, but I have seen 3 cases in US for sure. So it depends on whether it gets detected genetically or we put the symptoms together. When I say symptoms together, sorry, it refers to dysmorphic features, developmental delay, or psychomotor retardation. When these factors are put together, even if you're not doing a genetic analysis, you can actually correlate that probably this child has a 13q deletion syndrome. They have very characteristic features. They have thickened and anteverted earlobes, high and broad forehead, a prominent philtrum, a short nose, and thick everted lower lips. So putting these together is important because we will be able to counsel the family that it is another set of syndrome and you have to take care of the child according to these features put in together. Because a child with a developmental delay or slight psychomotor retardation might not be able to take care of himself, herself, and will need care even in the future. The next part is trilateral retinoblastoma. So, heritable RB must be screened for trilateral retinoblastoma, which basically means that these patients can have a midline CNS embryonal tumor or a pineloblastoma. Therefore, we must remember that 5 to 13% risk of trilateral RB development can be there in cases with heritable RB, and they have to be screened very well. So, whenever a patient comes with genetic predisposition or we find a genetic test positive, we always mention that we need to get the MRI done for this child. We have seen very small lesions being there, very small pineloblastomas, but they have to be monitored for growth. If they're small and persisting, we don't worry about them. But if there is growth, we need to involve a neurosurgeon in the management of the child. And how do we follow this up? We do MRI every 6 months till 5 years of age. We should also remember that these cases have higher risk of developing non-ocular malignancies. That means besides retinoblastoma, there can be other malignancies like osteosarcoma, soft tissue sarcoma, melanoma, epithelial cancers, which can occur in these patients in the later age, and familial RB has greater risk for these than the de novo RB1 mutation. And when we put the older protocol together, in the older protocol, EBRT used to be done very often. And now, when we put heritable RB and EBRT together, EBRT used to give a predisposition for the other second malignant neoplasms already, but with the heritable component, there is increased risk for second malignancies. So we must follow them up for life because it's important for us to note those features, and we must counsel the parent as well as the child, because when the child grows later and as an adult should know about their disease. The next part is clinical applications. Now, we have learned a lot about the basics of genetics. Now, where do we apply this? I would say that we must remember that knowing about the genetic predisposition gives us an alarming signal that there is risk of tumor in the same or the other eye. What I mean by this is, if a heritable retinoblastoma presents to you or presents to you in only one eye, there is need for regular and in-depth 360-degree examination under anesthesia for these children going in future. Because any time in the future, there can be a tumor which develops in the other eye. And I have seen that happening many times. So it's important that we keep a very close eye, and every time an examination under anesthesia is done, it is done as if it's a fresh eye. Don't rush through it. If you miss a very small tumor, it can be very dangerous for the child going forward. So the risk of tumor in the same and the other eye should be kept in mind. New tumors develop in the same eye and new tumors develop in the other eye. We must remember that there's long-term risk of non-ocular malignancies in these patients, and therefore knowing about the genetic predisposition helps us identify these non-ocular malignancies going forward. And it also helps us give a long-term prognosis assessment. I wouldn't say that the prognosis is bad, but it is relatively lesser than the non-heritable retinoblastoma. And again, keeping all these in mind, we are able to get cost-effective surveillance strategies, and we are able to put together the need for MRI as and when needed. Not every heritable RB needs to be going through MRI every time. When we do it in the initial few years, till 6 years of age max, we are able to identify a possibility of pineloblastoma. If a patient has pineloblastoma, then we go ahead with monitoring it. If not, then we can stop about it. But we should keep it in mind. We should tell the parent and the child about the possible symptoms that can be associated with the second malignancies. Now, next part is the genetic testing part. Now, this gets sometimes very confusing, but in the centers that have genetic testing, they will be very clear about it. In 2021, that is when I had in 2020, I started my fellowship, and I discussed this with Dr. Honavar, and we landed up starting OSDAs, that is One Stop Gene Shop, and we went through the entire thing. Whereas in the developing countries, in the developed countries like America, genetic testing has been going on for a very long time. But there are very few centers in India which do genetic testing, and I'm happy to note that that is increasing now. And there are multiple labs which are helping establish new centers throughout India. And in the last 5 years, it has grown multifold. So it's good to know that. And when we talk about genetic testing, important is to collect the right sample. A lot of people get confused at what sample is sent. It can be blood. Blood is the preferred sample for it. But unfortunately, if we have a situation, and we had that in our setup as well, that the child, I was enucleated and eventually the child succumbed, but we landed up giving the enucleated eye as fresh sample for genetic analysis also. So these are to be kept in mind. Blood is the preferred sample, not the tissue, but tissue, if used, has to be fresh tissue or a fresh enucleated eye only. Do not even think about biopsying the tumor. That can lead to more inadvertent results. So no biopsy ever, only enucleation if at all the child is going through it already. And you send the sampling for genetic analysis. Mostly it is next genome sequencing or MLPA. I will be talking about it in details in the next slide. And you usually get results in 4 to 6 weeks, which is the standard turnover. And further planning is based on the results. I always say that genetic counseling has two phases. One phase is before the genetic test is sent. That is when you sit down with the parents, you make them understand what is going on and what exactly it means for the child to have genetic predisposition. We do not really scare or emphasize on genetic assessment on the parents with unilateral RB because it starts scaring them a bit. But with bilateral retinoblastoma, because it has higher chances of having heritable retinoblastoma, it's important for us to sit with them and explain the germline mutation. We have to explain the entire counseling part, which I'll be covering soon as well. So the methods for detecting or tracking the mutations in RB1 gene, moreover, I would say we use the DNA sequencing, that is the next genome sequencing, which identifies approximately 70 to 75% of all the RB1 mutations. If not, then we'll end up doing MLPA. And MLPA basically is multiplex ligation dependent probe amplification. This is to identify deletions or rearrangements of one or several exons, which account for 16% of aberrations of RB1. So when we say which test is to be done, a lot of people get confused that both MLP and NGS need to be carried out. I would say we send the sample first for NGS, that is next genome DNA sequencing. If at all that is not able to identify the mutation, then we go ahead with MLPA analysis. Both are not needed because they land up being very expensive. Unfortunately, these tests do not get covered in insurance in India, whereas these get covered in insurance elsewhere as well. So, like in other developed countries. So, what we do is that we send only one testing and we supplement it with the other if it's really mandatory. And we also keep it in mind, as I mentioned earlier, that 5% of the children might not have or might not show genetic predisposition, but they can have it in future. And we've had cases like that. So, we must counsel the family accordingly. Going forward, this is a very beautiful table which has been given by the Canadian National Guidelines for Genetic Testing in Retinoblastoma, and I've tried to make it easy. So, this genetic testing table is only for the non-familial RB proband. That means that the child does not have a significant history of any of the parents or any of the family members having retinoblastoma. If the child has such a history, then we don't need to go through all this because that means we know that it is genetic. But if at all there's no history and the child has bilateral RB, even the parents with unilateral RB, I mean, the children with unilateral RB, they're welcome to have their analysis done as well. But for these cases, what we do is we start with this part. So, if at all there is RB1 mutant allele identified in the proband blood, as I mentioned, blood is preferred. So, in case it gets identified, then we This is the child testing positive for RB1. So then we test the parents. If the parent is also positive for a mutant allele, then what we do is we test the relatives. When we say relatives, it means the close relatives. That means the offspring, the parent, the sibling, the grandparent, uncle and aunt, they are distant relatives, but they can have that as well, or any infant cousin of the bilateral proband. All of these people can get tested. Yes, it's expensive, but it's sometimes good to know that, because then we can hold the counseling accordingly. If they are positive for mutant allele anywhere, if any child is positive for mutant allele, we are pretty much sure that this child has 45% chances of presenting with retinoblastoma in future. So we do clinical surveillance. What is the surveillance protocol? These protocols have been given by different people. Everybody has their own set of EUA protocols or clinical surveillance protocols, and that's okay. It's not a problem. What we suggest is that we do 6 clinical visits and 7 EUAs in the first 7 years of life, and lifelong counseling for second primary cancers. Now, in case the parent is negative, the child is positive, then the risk of unaffected parent is mosaic. That means that there is not much of a possibility of this child carrying it forward. If overall, if the child also is negative, and we continue with the clinical surveillance of relatives, we do not need to do a genetic analysis of everyone. We do not need to spend money on doing genetic analysis of the parents. That means if the child doesn't have it, definitely the parents don't have it. And again, the risk the proband is mosaic is 10% in these cases. Putting all of these together, relatives antecedent to a negative test, we do not need further testing. There is no need. Even if the parents come to you and say that no, we need to get it done because we want to be sure, you have to sit down with them and tell them this is waste of money because you're not really getting there with anything. However, in developed countries, they'll end up proceeding with testing of parents, even if the child is positive or negative, because it gets covered. And when, if at all, the child is positive, the parent is positive, and the relatives are negative, that also brings it down a complete 0.01% of a possibility. So there's no clinical surveillance required in these cases. I hope that this simplifies it, but this is an important table. If you do not understand the table in the first go, it's okay to sit on it and try to read it again and again because it's very important. It answers many questions. I probably sat on with this table so many times to get it right in my head. So when we go forward, a lot of analysis, when we talk about DNA component, DNA in general has been studied even in the aqueous chamber, and a lot of studies have been are going on around the world, and it was initiated by one of the labs by Dr. Jessie Berry herself, and it just shows that tumor derived cell free DNA can be isolated from the aqueous tumor itself. So that means that we do not need to go in, we can do the analysis way early, and this establishes that liquid biopsy, it can compensate for the part that we cannot biopsy the tumor itself, and there are certain biomarkers that we cannot look for. So without touching the tumor, we can actually do a prognostic study, and it shows that the aqueous humor assessment is good prognostic and diagnostic method. Another thing which is being discussed of late, and that is metabolomics of retinoblastoma. What it means is that we take the serum sample of the RB patients, and this is a very good study where it was compared that healthy controls and RB patients were studied together. The samples are treated with an NMR spectroscopy, and what they observed was there were certain components and certain products, I would say, the serum signatures, which were common in bilateral and unilateral RB. And it has been established that these components, if present, they indicate the possibility of retinoblastoma, whether bilateral or unilateral. They also showed that this is more common in bilateral. So when they compared their cases, bilateral retinoblastoma had higher predisposition of these serum markers to be present than unilateral RB. So going forward, and as I was discussing this with Dr. Samiksha, she will be happy to discuss this in after the presentation. She has been doing a lot of work on metabolomics, and I think as we were discussing that a lot of studies or manuscripts are currently in pipeline for the same. So the metabolic perturbation in bilateral patients signifies the severity of the disease. So this can help us assess severity, the laterality, and this is a non-invasive method, and therefore it has a potential to help in the future. We must remember sibling screening has a very, very important role. We need to chart out the family tree and list every member. The moment you get a patient with retinocytoma or retinoblastoma, it's important to sit with the family tree and list every member. Note the age and prior eye examination of all the siblings. Please advise them to undergo screening. Sometimes they feel it's just a small thing. How does it matter? It matters a lot, and I will be explaining that by the case scenarios in future. With careful clinical screening, if at all it's a heritable RB, 50% of the cases can be diagnosed by 2 months, and 100% can be diagnosed by 1 year if the child is heritable RB. And prefer the genetic assessment of sibling if the RB gene is mutated. That means that if at all we know about the genetic predisposition and there's a sibling being born, it's important to do the genetic assessment of the child as well. But again, as we had said, that if at all it's there in the family, then it might be for the sibling as well. So you can even avoid it. This is the protocol that we follow, and that is that if at all at birth, if at all we know that the first offspring has retinoblastoma, then we tell the parent to bring the child as soon as possible. Please remember that the first examination can be within the first 2 weeks of birth. Yes, we can give a very short anesthesia and we can screen the eye. So it's important because a lot of heritable RB cases are natal. That means that the child develops the retinoblastoma in the eyes while during gestation. So we can assess it early as well. From birth to 3 months, we do the examination every 1 month. I would say it goes 1, 2, 3, 4, 6, and it's 3 months to 1 year is every 2 months. 1 to 2 years is every 3 months. 2 to 3 years every 4 months. 3 to 5 years every 6 months. It's important. We have seen cases where new tumors have appeared. It's never a pleasant scenario, but it occurs. So, giving you brief case scenarios, and these are not, I'm not going to explain the treatment part or the management part, but what exactly happened. So this is a child, 1 year, 2 month female child presented with bilateral RB, right eye group B, left eye group D, no familial history, IVC was initiated. After the treatment completion, all the parents were happy and they are controlled about it. The parents conceived another child, but didn't contact us. They didn't mention to us that what is going on, and then they promptly brought the child at 2 months of age, and the child we did 360-degree evaluation. You can see there's a peripheral tumor as well, and it was bilateral group A. In this child, we were able to initiate focal treatment because it's very tiny tumors. But remember, any bilateral case can present with more tumors in future. So even if you're doing focal treatment, there's a possibility, considering the germline predisposition, that we might need to initiate IVC later. Two schools of thoughts. Many people feel that even if it's a small tumor, we know it's germline, we go ahead with IVC in the first go. But the child is too little. The child is 2 months of age. So we try to avoid IVC initiation till the child grows stronger. The next case is where an 8-year-old male child presented with unilateral RB. As you can see, it's unilateral. And left eye has orbital RB, and on MRI, the child even had intracranial extension, no familial history, and we started with high dose IVC as per the orbital RB protocol. The child succumbed in 6 months. Now, the parents got scared and hesitantly they revealed that the elder sibling has also had white reflex. Now the child is 10 years old, but 3 years back, the child was evaluated elsewhere and was told that she has some lesion. We told them to bring the child to us. And but we also know that 3 years back there was no family history charting done, no genetic evaluation, no sibling screening. Otherwise, this child would undergo sibling screening as well. And the parents brought the elder sibling in, and there was a retinocytoma in this child. And this is in the right eye, there's a nice retinocytoma. So if at all, at this time, there was an alert moment for the sibling to be assessed, probably we would have caught his retinoblastoma early. And this girl screening continues with us, and we have even informed the parents about genetic counseling part. Another case scenario is 2 years, 4 months old child presented with unilateral RB. It's a group B, no family history, treatment initiation with IAC. Child responded very well with regression, salvage, and achieved on all three fronts. Mother reached out to us after 2 years to inform that she's looking for adoption options. And it kind of surprised us that why is she looking for adoption. Then she told us further that she underwent medical termination of pregnancy locally 1 year back because she was scared that the child is going to have retinoblastoma. But she didn't realize that we have counseled her that this is a unilateral RB. It's very less likely for this child to have a sibling with retinoblastoma. It's not really needed. So, despite genetic counseling, the parents do not have clarity. So, it's important to stay in touch with them because there's one less than 1% of chance of RB within sibling. And pre-implantation genetics was advised to this, and I'll be talking about this in the next part. It's very brief, so I think only a few slides are left, so that we are in time. And case 4 is a 6-year-old female child diagnosed with unilateral retinoblastoma, right eye group E, no familial history, but has a heterozygotic twin brother. So female child with a twin brother. Poor response to IVC and focal treatment, we had to enucleate due to refractory RB. But the brother is screened regularly. It is important to know that heterozygotic twins might not have the heritable component even if the child is unilateral. I've put this case specifically because a lot of people get confused that the twin is supposed to have the same genetic predisposition, but it's not necessary. There's no evidence of retinoblastoma in this child. Now the twins are 18 years old. That means that they have been going on being screened for a long time. And now we sat with the parents and the twins and we explained to them about pre-implantation genetic counseling for future planning. What it means, I will be talking about in this last slide of mine. So when we talk about genetic counseling, I've tried to put it together in a mnemonic form. G stands for genetic assessment of the child plus minus parents. Do not need to start off with parents automatically. E stands for examination of all family members. Even if the child is bilateral, you do not have a genetic facility, you can examine everybody clinically, and that's okay. N is natal. That means prenatal diagnosis is possible. We can do that by chorionic venous sapling at 10 to 12 weeks or amniocentesis by 15 weeks. These can indicate two things. One, whether the child is going to have retinoblastoma or not and what we have to do. Or the second thing is we can even cases have been done where preterm delivery has been done to take care of the child early. I have never seen that, but it has been reported. So we must do prenatal diagnosis. E is to explain the psychosocial aspects and needs. These children require a lot of psychosocial support, and the parents need to understand that. T is for tumor screening for second malignancies. I is pre-implantation genetics. What this means is that when the implant, when we know that the child has heritable RB, when they grow up and they are planning their family, what they can do is that they can go ahead. There are labs which do this, and they proceed with in vitro fertilization. What they do is they do pre-implantation assessment whether the genetic component of RB is present or not, and then they land up creating a new embryo which is free of retinoblastoma, so which is genetically confirmed. And I've seen cases in US which have led to a pre-implantation benefit, and I would suggest that to be done in India as well. It might take time, but I guess we are already at it. The first case is probably about to happen in many regions that I'm aware of. C is counsel regarding future advances. A lot is going on, a lot is going forward, and it's important for these people to keep a tab on the genetic advances going forward. We might see a lot of changes in future. We might be able to eliminate the genetic component of RB anywhere in future. So it's important to do that. S stands for sibling screening regularly. I would say that these components are important for genetic counseling. So to conclude, I would say that RB is a genetic disease with genetic assessment and counseling as integral parts of providing the care. Mutation 13q14, heritable or non-heritable or NMYC amplification, autosomal dominant inheritance. All bilateral cases have germline mutation. Non-germline cases are mostly unilateral. AJCC addition now has the H inclusion, which means that it is important and it can be associated with 13q deletion syndrome, trilateral RB, second malignant neoplasms. Clinically, it is better to do this for early diagnosis and better prognosis. Genetic testing can be done via NGS, and if does not work, then MLPA. Sibling screening is mandatory as per the age, the protocol that I've shown. Genetic counseling eliminates a lot of misconceptions. You'll be surprised as to what the parents think. I still remember being shocked when I was told that the mother proceeded with medical termination of pregnancy somehow locally. And pre-implantation genetics is the game changer. Please go ahead and tell your patients about it. It's so important. And I would say thank you so much. RB is all about one day at a time, and we are going ahead in the right direction. Thank you so much.
Thank you, Dr. Volka, for such an illustrative talk. I think it's cover almost all the part A to Z of the genetics and other thing.
Thank
Dr.
you, sir.
Devjyoti, sir.
Yeah, Rolika, nicely put together, very comprehensive, and I think distilled to a level of simplicity that is hopefully easy for everybody to understand. For us, when we were trained to deal with retinoblastoma, genetics was very far away from our training modules, and it was not very much a part of our basic training during our fellowship days. So we needed to catch up with what it was as we started working on our own with the patients. And to be absolutely truthful, we still have a long way to go by way of providing this particular, let's say, a kind of privilege that the patient has in certain scenarios in our country, especially in smaller cities, the tier 2 cities. But as you mentioned, there are certain labs which are now coming up with a lot of support, and they are reaching out to pretty peripheral regions in the country. And we have hope that in the coming years, we will be able to provide this as a routine procedure for all patients with retinoblastoma who come in for screening and treatment, which is what it should be actually. So
Right.
from the information that we now have from so many years of genetic studies and the utility that it has provided us with, the way it has helped us strategize our screening protocols and to actually sort of, allocate the available resources, because we are constantly in a resource constrained environment. So if there is something that helps us allocate our available resources in a more effective or a more efficient manner, then genetics certainly is one of the best things that can be put to use for us.
Right, so I would actually add this part in support of Sir's statement that there are many NGOs, like we have support of CanKids also, which is supporting the genetic assessment. And for every new child coming in, they are agreeing for genetic assessment, which is a great provision, because that means that from any socioeconomic strata, we are able to assess them. But we prefer to do that for bilateral cases because it is 85% chances of them having something.
Yeah, I agree. And yes, it's true that there are several NGOs who are now coming up, and CanKids is one of the prominent ones. But we also have to understand the challenge of the sheer number of cases that our country has in terms of new cases every year. That's a huge challenge. And yes, of course, the bilateral cases are the ones in which we need to actually start off with. And identifying a de novo heritable mutation in a particular proband is actually a game changer for the subsequent years of that proband as well as for the generations that follow that proband. One of the challenges that I face with my patients, especially the parents of a proband child who is detected with a de novo RB, and it's not a familial case. The parents, the children who are familial heritable retinoblastoma, those parents are usually the relatively easier ones to convince about genetics because they have already seen the manifestation, the phenotypical manifestation of the disease for at least 2 generations. But for
Right.
parents who are completely unaffected and then they have a child with a heritable RB with a de novo mutation, it is quite challenging in our scenario as of now. People don't have that awareness and that consciousness. They need to be really counseled well about what impact this testing can have on the subsequent generations. That is something that they fail to grasp at this point of time because they have never encountered the disease in their own generation.
Right. So,
It certainly comes on in the next generation. So that is one challenge that we do encounter, but things are definitely changing. So
yes.
once you get to talk to them, sit them down, explain things to them as to what you're trying to do, why you are trying to do, and what impact this is going to have in the future, then people become more understanding. And I'm 100% sure that with persistence and with time, things are going to become much, much more better.
That's true, sir. I forgot to add one point, as you mentioned here, that when we send the blood for investigation, like for example, we associate with our lab being MedGenome, they have the facility that they have genetic counselors which who contact the parents and provide them specific genetic counseling separate from the ones that the doctors do, which is a very important and good provision because doctors do not have that much time sometimes. Even if we explain certain pointers, they are the experts sitting with every single point to cover, and they give
True.
time like half an hour or so.
Yes, they
And
they actually start right from mapping out the pedigree and doing the pedigree charting, and then generation by generation explaining to the parents as to what has happened, what possibly could happen in the subsequent generations, and that actually is a big, big help.
right, so. And Dr. Samiksha,
Thank
would
you,
you
sir.
like to give your inputs too about, as I just mentioned in the presentation, I would say that openly that I don't have much of experience with metabolomics, and I would just request Dr. Samiksha to elaborate on that.
Yeah, I just wanted to touch upon a few pointers. As Devjyoti sir and you rightly mentioned, the pre-genetic testing counseling is extremely important. They have to be made to understand the importance of why we're doing the testing. And we're fortunate to have Dr. Anuprita Ghosh, who is a geneticist, who is with us in Narayana Nethralaya, and her team always, every new child that comes to us is undergoing genetic counseling, irrespective of whether they undergo the testing or not. So the implication I found about this is that when they have a second child, they come to us and they let us know, oh, we're pregnant, we're expecting the next child. So we are able to schedule their EUAs well ahead of time, irrespective of whether they're able to afford the test or not. So it makes a huge difference. Even the counseling component it makes a huge difference in the management of these families, not just the genetic test itself. And there are several terms that come up in the report itself. Pathogenic, likely pathogenic, not pathogenic. So the understanding of these terms, even as a clinician, I am not so good at it. But a geneticist, they understand what it means. Like certain mutations have known implication in the disease, or some of them are evolving, or I mean their role in the disease process is evolving. So that's what the implications of these are better explained by our geneticists. So I think that makes a huge difference to the management of these patients. And one more practical application of the genetic testing I found is there are certain children who cannot undergo EUAs as frequently as we would want them to. Like I've had children who have seizures secondary to sevoflurane induction. I've had children with liver problems who cannot undergo EUAs that frequently. So having this genetic test report with us can, puts me at peace that even if I stagger the EUAs a little, I'm not putting the child at risk of any, at a recurrence that I might miss in and not caught in time. And then another thing was cost. I think maybe about 5, 6 years ago, I think the cost of this testing for each child was about, I don't know, 40,000 to 50,000.
Yes.
Now, as there are more and more families and children who are undergoing this testing, the cost has been brought down. Now, I think each proband child is being tested for around 13,000. 13 to 15,000.
10
So
to
I think
15,000.
the more we refer these children and the more families come forward to get this testing done, the cost is going to come down for us. So I think it's a good idea to encourage everyone to go ahead with these. Yeah,
That
and
also happens because they are able to do it in bunches, and that
yes.
saves them amount, because when they are using the serums and that for the testing analysis, when they put it together, it's like they even told us that if you're giving me 5 cases at a time, then I can do it for the same price.
Yes.
So it helps.
So yeah, the more we encourage them, the better it is for our children, and it is for the families themselves. And about the metabolomics that you asked me to mention, so Narayana Netralaya has the Grow Lab, which is headed by Dr. Arka Ghosh. They've been working for many years on the epigenetic or the post-genetic pathways that are so important in how the disease is manifested. Now, even if the child has the RB1 mutation, how each child presents is different. And there are so many post-genetic factors, like the post-transcriptional factors that come into play to actually determine what kind of disease we're seeing. And so much research has gone into this. They've identified microRNAs, which are important, upregulated with RB1 overexpression, which actually prevent retinoblastoma. And these can be introduced into retinoblastoma eyes to drive down the tumor burden. Then there are certain metabolic pathways that have been identified, like the RB cells are more dependent on non-glucose metabolism, more on fatty acids, and more on glutamine. So these pathways, when they are inhibited, these RB cells, they become more sensitive to the chemotherapy that we're giving. So they have practically demonstrated that the effectiveness or the effective dose of topotecan can be driven down by adding an additional factor that will inhibit these pathways. And there are certain other molecular targets also that are being tried, certain genetic targets that help in, again, increasing chemosensitivity and decreasing the dose that we're giving. So practically, it makes a lot of difference, especially in these resistant cases. I'm sure we've all encountered some very resistant cases who are not responding to even the high dose chemo that we're giving. So if we have further adjuncts to help us deal with these cases better, I think that's where the future of every cancer therapy is headed at present. What we have is not enough, and we need to find better ways which are more effective and less toxic that will help us work further and less invasive. So another thing that we've been working on is tier biomarkers. So as a surrogate, it helps these tier biomarkers that have been identified, they corroborate well with the intraocular tumor. And below a certain cutoff level, they indicate that there are chances for recurrence. So we keep these children under tighter follow-up. And above a certain level in these tiers, when we find this biomarker, they have lesser chances of a recurrence. So we can relax the EUAs a little. This is irrespective of what we find on genetic testing. So I think Dr. Jesse Berry's group also, they had done a lot of work on these cell-free DNA, and that's what they were trying to get, which eye is going to survive, which eye is not going to survive. Is it practical to try to, save this eye, or are we putting the child through too much? So these are questions that we all have, we all face practically when we're treating these patients. And I think we have a long way to go, but I think we're all headed there.
Right.
I'd love to
I think
share
as
all
you
of
said,
those.
as Devyuti sir said, that in 5 years, a lot has changed.
Yeah.
and a lot is going to change at a faster rate in the future. Even in my tenure with Dr. Shields when I was in US, even then I realized that they are pretty much stable right now because a lot had changed for them in 10 years now. But they've been following the same protocols because they're working. And now we are following the same protocols, and I think that's working for us as well. So we're going to go at faster pace going forward.
Dr. Suganeswari ma'am, what is the protocol at the Sankar Netralaya
So
for
actually,
this testing and
yeah. So we've been currently doing this almost genetic testing for the past 20 years, I would say, even before I started doing oncology. Like all my seniors, Dr. Lingam Gopal, Dr. Tarun Sharma, Dr. Mahesh Shanmugam, who were there, they were all pioneers in retinoblastoma. And the most important thing is, in fact, our first case of endoresection, if I happen to see the old files, it was almost done 15 years back, a tumor resection. With that early, people had done a lot of immense work. So I guess Dr. Rolika has done a wonderful job of presenting everything so neatly, and Dr. Devjyoti and Dr. Samiksha have brought down points, in fact, elaborate points. What I would like to add is, like, when exactly, if you have a planned pregnancy or an unplanned pregnancy, like a pregnant person coming to you with probably an elder sibling having retinoblastoma, when would you like to do it? That is one thing which I thought that point got missed out. So I thought I will tell that if a pregnant person is coming probably within 20 weeks of pregnancy, at that time, then one can probably do an amniocentesis to detect the mutation. And if your patient comes to you at 24 weeks, would you still be able to do it? Then no, you cannot do it. If a person comes to you at 24 weeks, you might only tell them that they have to continue pregnancy because they cannot do a medical termination of pregnancy, because retinoblastoma is in India or wherever in the whole world, it is not considered lethal for us to terminate pregnancy if you have a diagnosis of retinoblastoma. They are only allowed to continue pregnancy because after 24 weeks, that is what it is. And one more thing is these turnaround time for these genetic analysis, how much ever pressure you put on them, it cannot be anything less than 4 weeks. You definitely need 4 weeks in time. So if your patient comes only at the 20th week, again, you're cornered, because you at that point in time, you may have to take a decision based on that, because the lady is not having time for us to give. So that these are all things one should understand, what are the implications when we do. And of course, another thing what you must always tell your patient, that is, whenever these amniocentesis and all these things are done, prematurity is yet another common thing which we encounter. So one must be geared up to face that thing of prematurity, because if they are in cities where one cannot manage prematurity, you should not push them into having other set of complications like retinopathy of prematurity. So, and also the lung maturity, everything. So the NICU has to be really good for us to take care of these premature children who are having these problems. And one more thing is, how do we monitor if you know that, yes, the child has got the mutation and this is already crossed 24 weeks? How do you go about doing it? So in those situations, one must also ask for what is called as MRI. So they can do a MRI based testing wherein you can monitor the growth of the tumor, and once you know that it is crossed the 32 weeks or 34 weeks, then you could consider termination of pregnancy at that point in time, deliver the baby prematurely. But yes, of course, the risk of ROP and all those things to be discussed with the patient. And then after that, you can probably take care of giving chemotherapy. And now we are almost giving chemotherapy. I would say in the last 3 months, we have done at least 2 neonates where we had given chemotherapy for children who are less than 28 days of life. That is something which we have not seen earlier initially, but now because of the ROP program, which is caught up in India very well, these retinoblastomas are getting invariably diagnosed. So that is one thing which I would like to add. And yet another point is, like, these genetics definitely help in monitoring, like how you can monitor, face up your follow-up. Like if you don't know whether lateralization would occur, not occur. And this good point which Dr. Samiksha said, you can probably reduce the number of EUS. That is a wonderful thing which we are all doing with unilateral retinoblastomas. So I think genetics has more to evolve, like for instance, in terms of treatment also, like whether you have platinum resistance or no. If you have N-wing positive, then you will know that. So these are certain things which are like now in evolution. Of course, beyond that, we also have tumor genetics, like supplying the tumor sample for that, which currently not many institutes are doing. But yes, that is something which you need to establish, because you need to correlate whether you are having the same thing, both the tumor and this. That is what I would like to say. And I would like to point out one interesting point, like share rather one case which we had. That child had glaucoma, congenital glaucoma. And when we did the genetics for congenital glaucoma, this retinoblastoma gene was positive, and that got picked up. So now that is see, these are all things which are advantages of genetics, because the child never had a retinoblastoma till date we are monitoring, but that gene is positive. So these are all things which we are learning right now with evolution of our medical field. And I must thank all of you for, having me here. So, I mean, it was good learning experience for me, sitting and listening to what Dr. Rolika said. And it's wonderful. Thank you. Thank you for having me here.
Thank you, ma'am. Ma'am,
Thank you,
I have
ma'am.
a question for you, ma'am. As you mentioned that you are okay with giving the chemotherapy in the initial early months as well.
Yes.
For example, I know that RB management is very different everywhere, and that's okay.
Yes.
But for example, if a case presented to you with bilateral, like
Mm.
2 months, the sibling of RB presents with 2 months and with a tiny tumor, the peripheral small tumors, would you still be okay with giving IVC initially, or would you prefer to do focal therapy? I
So
understand
you,
that systemic can be
yes.
managed, but what is your
Yeah.
opinion?
So if it is a posterior tumor, I would still, if you have a posterior tumor, say within group B tumor which you have, in that case, I would definitely not do a laser therapy. I would rather do a chemo reduction only. But like you pointed out, peripheral tumors, I'm okay to definitely do only whether you do a TTT or whether you do a cryotherapy. That also is pretty much fine, because for me, the earliest I have treated is probably day 2 of life. And a child who was for day 12, I have done only laser therapy in the beginning. So it was like, so day 12 and all, we manage it like how we do for ROP management only. We don't even give anesthesia for them. We just do it off like that. And most of the time for us, being retinal surgeon, the thing becomes easy is when we see these babies, we are so used to 5 months, 6 months also, we are able to handle them without EUAs also. So that is one advantage, where you can manage the retina very well. That's what I think it's the easiest part of it. So posterior tumors, if it is within the macula, I would definitely not consider doing a focal treatment. I would rather give it, shrink it, because sometimes you see it disappears also. So so nowadays it's actually the neonatologists manage the IVC for babies who are less than 28 days. So they do really a good job now.
Right. Thank you, ma'am.
Thank you.
Thank you, everyone. Thank you, Dr. Rolika, for such an illustrative talk. And all our expert panels, Dr. Devjyoti, Dr. Samiksha, and Dr. Sugami, for giving us the valuable and useful tips for each and every step. With this word, I would like to thank all the viewers, and from the team of AJCC, thank you all. Thank you, everyone. Thank you.
Thank you, everyone.
Good night.
Thank you.
Good
Thank you.
night.
For
Good
you,
night.
good morning, Rolika. Thank you.
Good night, everyone.